You know when you hear about serious health problems, and the terms just fly past, like all these acronyms and complex names.
Absolutely. It can feel overwhelming trying to piece it all together.
Yeah, you just want someone to, lay it out clearly, show how A leads to B leads to C.
Make sense of the alphabet soup.
Exactly. So that's our plan for this deep dive. We're tackling a really critical sequence, systemic inflammatory response syndrome, or SIRS.
Then moving on to sepsis.
Shock, and finally, multiple organ dysfunction syndrome, MODS.
And we're drawing from some solid material, chapter 46 of a Patho Final Exam Objectives document.
Right. So the goal here isn't just reading definitions. We want to get under the hood, understand the progression.
Understand how the body shifts from one state to the next, from that initial inflammation right through to potential organ failure.
So let's strip away the complexity and get to the core. Ready to jump in?
Let's do it, starting with SIRS.
Yes, SIRS, systemic inflammatory response syndrome. What exactly is going on there?
Okay, so SIRS is essentially the body mounting this huge inflammatory response across the whole system.
Body-wide inflammation.
Right. But here's the crucial first point. This massive reaction, it's not initially triggered by an infection.
Oh, infection. That's interesting. So if it's not germs, what does set it off?
Well, the source points to things like major trauma, think bad accidents, or extensive burns.
Okay. Physical injury.
Yeah, or things like pancreatitis, which is a severe inflammation of the pancreas itself, or even ischemia, where tissues aren't getting enough blood, enough oxygen.
So major stresses on the body, even without a bug involved, can trigger this massive code red inflammatory response.
That's a good way to put it. The alarm system goes off, but the trigger isn't necessarily an invader.
So how would doctors know if someone's in SIRS? What are the signs they're looking for?
There are 4 key criteria they track. First is temperature either high, like over 38 Celsius, or surprisingly low, under 36.
High or low temp. Got it.
Second, a fast heart rate over 90 beats per minute.
Tachycardia.
Third, rapid breathing. So more than 20 breaths a minute, or if they measure blood gases, a low PaCO2, meaning they're blowing off CO2 fast.
Okay, fast heart rate, fast breathing. What's the fourth?
And fourth is the white blood cell count. It can be really high, over 12,000, suggesting a big immune mobilization. Or, paradoxically, very low, under 4,000, which can also indicate a dysregulated immune system.
Wow. So hitting a certain number of those flags signals a major systemic problem, even if we don't know the exact cause yet.
Precisely. It tells us the body is seriously stressed and reacting strongly.
Okay. Now, what happens if an infection is the trigger? That's where sepsis comes in, right?
Exactly. Sepsis is defined very specifically now as life-threatening organ dysfunction caused by a dysregulated host response to infection.
So infection is the absolute key here. It has to be an infection involved for it to be sepsis.
Yes. The body is trying to fight the infection, but its response becomes harmful, damaging its own tissues and organs. It's gone haywire.
And I saw the term severe sepsis mentioned. How does that differ from just sepsis?
Good question. Severe sepsis used to be a distinct category, but guidelines have evolved. Now, sepsis itself implies organ dysfunction. However, thinking about it as a progression is still useful.
Okay.
So maybe think of it as you have sepsis, infection plus dysregulated response causing organ issues, and then things can worsen.
Which brings us to septic shock. That sounds bad.
It is very bad. Septic shock is a subset of sepsis where the circulatory and cellular or metabolic abnormalities are profound. Clinically, it means persistent low blood pressure hypotension that needs vasopressors to maintain a certain level.
Vasopressors. Those are drugs to raise blood pressure.
Correct, like norepinephrine. And this low pressure happens despite giving the patient plenty of fluids. Plus, they often have elevated lactate levels, indicating cells aren't getting enough oxygen.
So if fluids aren't enough, the pressure stays dangerously low and the cells are struggling. That really paints a picture of severity.
It does. It means the body's ability to deliver oxygen is critically failing.
Now, the chapter mentions shock more generally, too. How does septic shock fit into that bigger picture?
Well, the basic definition of any type of shock is inadequate tissue perfusion and oxygenation. Essentially, not enough blood and oxygen are getting to the tissues.
The delivery system failing, like you said.
Exactly. Septic shock is just one type where the cause is that severe infection-driven response leading to circulatory failure.
And the other types mentioned hypovolemic, cardiogenic. Just briefly, what causes those?
Sure. Hypovolemic is from losing too much fluid volume, like blood loss from trauma or severe dehydration.
Makes sense. Volume loss.
Cardiogenic is when the heart pump itself fails, maybe after a massive heart attack.
The pump's broken.
Neurogenic often relates to spinal cord injuries messing with nerve control of blood vessels, and anaphylactic is that severe allergic reaction causing widespread vessel dilation.
Different triggers, but the same end problem. Tissues not getting oxygen.
Correct. But for our SIRS sepsis pathway, septic shock is the key type of shock we're focusing on.
Right. So SIRS, inflammation, maybe no infection.
Yeah.
Sepsis, infection plus organ dysfunction. Septic shock, sepsis plus circulatory failure. What's the next potential step down this dangerous path? MODS.
Exactly. MODS, multiple organ dysfunction syndrome. This is where things get extremely critical. It's the progressive failure of two or more organ systems.
The two or more, wow.
Yes. It typically follows a severe insult like sepsis, shock, major trauma, where the initial problem triggers a cascade that starts taking down multiple organs: lungs, kidneys, liver, clotting system.
A domino effect, essentially. The whole system starts to crumble.
That's a good analogy. The interconnectedness means failure in one area puts immense strain on others.
Okay, let's connect this back to what you might actually see. For SIRS, what are those clinical signs again?
For SIRS, you're looking for those criteria: fever or low temp, fast heart rate, fast breathing, and that abnormal white cell count. Signs of systemic stress.
And if it progresses to sepsis, what adds to that picture?
With sepsis, you'd expect signs of the infection itself, maybe a cough and lung findings for pneumonia or urinary symptoms for a UTI, plus those SIRS signs. And crucially, evidence of organ dysfunction starting like confusion or altered mental state, maybe a drop in urine output or that falling blood pressure.
So infection signs plus SIRS signs plus early organ trouble signs.
You got it.
And then in shock, what are the really stark signs?
Low blood pressure is the big one, often needing medication support. The skin might feel cold and clammy.
But you mentioned something about early septic shock.
Yes, that's a key point. In the early phase of septic shock, sometimes called warm shock, the patient might actually have warm, flushed skin because the blood vessels are so dilated initially. Later, it typically becomes cold and clammy.
That's a really important distinction. Warm skin doesn't rule it out early on.
Not at all. Other signs include a weak, thready pulse, and definitely that low urine output oliguria showing the kidneys are struggling with perfusion.
Okay. And if it reaches MODS, what are the manifestations then?
With MODS, you see the specific organs failing. So severe difficulty breathing, needing a ventilator that could be ARDS, problems with bleeding or clotting everywhere that points to DIC, kidneys shutting down, needing dialysis, that's AKI, liver enzymes going up, maybe jaundice, that's liver dysfunction.
It's basically seeing the failure play out in each affected system.
Correct. The symptoms directly reflect which organs are failing and how badly.
This progression is really stark. The document also talks about stages of shock. Can you walk us through that timeline?
Sure. It often starts with the initial stage. This is sneaky because it's happening at the cellular level. Cells aren't getting quite enough oxygen. They might switch to less efficient energy production. But outwardly, the person might not show obvious signs yet. The body's compensating.
Subclinical kind of hidden changes.
Exactly. Then comes the progressive stage. Here, the compensation starts to fail. Metabolic imbalances worsen, you get acidosis, lactic acid builds up because of that lack of oxygen. Blood pressure drops more noticeably. Organs show clearer signs of dysfunction.
The cracks are really starting to show.
They are, and if it's not reversed, you enter the irreversible stage, sometimes called the refractory stage.
It's reversible. That sounds final.
It often is, sadly. At this point, the organ damage is so severe and widespread that even aggressive treatment can't turn things around. The shock doesn't respond anymore. Cellular death is extensive, and mortality is extremely high.
A very grim picture of how far things can decline.
It underscores why early recognition and treatment are so critical.
Absolutely. Now, within MODS, you mentioned a few specific conditions, ARDS, DIC. Can we touch on those briefly? What is ARDS exactly?
ARDS is acute respiratory distress syndrome. It's severe lung inflammation. The tiny air sacs, the alveoli, get leaky and fill with fluid. This makes it incredibly hard for oxygen to get from the lungs into the blood.
So profound breathing difficulty and low oxygen levels.
Yes, often requiring mechanical ventilation with high oxygen levels and pressure support.
And DIC. You said clotting and bleeding. How does that work?
DIC, disseminated intravascular coagulation, is paradoxical. You get widespread abnormal clotting in small blood vessels all over the body. These tiny clots can block blood flow and damage organs.
Okay, too much clotting.
But this process uses up all the clotting factors and platelets. So then the patient can't form clots where they need to, leading to severe, uncontrollable bleeding.
Wow. Clotting and bleeding at the same time. That sounds like a nightmare to manage.
It's incredibly challenging.
What about ACS, abdominal compartment syndrome?
That's when pressure builds up inside the abdominal cavity, usually due to fluid accumulation or swelling after major surgery or trauma or severe pancreatitis. This high pressure squishes the organs and blood vessels inside.
Reducing blood flow.
Exactly. It reduces blood flow to vital abdominal organs like the kidneys, intestines, liver, compromising their function. It might even push up on the diaphragm, making breathing harder.
Like internal strangulation almost?
In a sense, yes. It needs urgent decompression often.
And AKI. We mentioned kidneys failing.
Acute kidney injury. It's a sudden drop in kidney function. They can't filter waste, balance fluids, or regulate electrolytes properly. Waste products build up, fluid balance goes haywire. It contributes significantly to the overall illness in MODS.
These really highlight how one system failing impacts everything else. Given all this, what are the main treatment strategies?
It's really about two things: treating the underlying cause, especially infection and sepsis, and supporting the failing organs.
Okay, so step one, if it's sepsis, get the infection.
Absolutely. Prompt, appropriate antibiotics are crucial, like within the hour, if possible, for septic shock. Identifying the source of infection is key, too.
And supporting the organs? Fluids seem important.
Fluids are foundational, especially in shock. Giving IV fluids crystalloids like saline, sometimes colloids, helps restore volume in the blood vessels and improve blood pressure and perfusion.
But sometimes fluids aren't enough for blood pressure, right? You mentioned vasopressors.
Correct. If blood pressure stays low despite adequate fluids, vasopressors like norepinephrine or dopamine are used. They constrict blood vessels to push the pressure back up.
What about breathing support for ARDs?
Mechanical ventilation is key. Using a ventilator to help breathe, deliver oxygen, and sometimes use special strategies to protect the lungs while they heal.
And for the clotting chaos of DIC.
That's tough. It might involve giving blood products like platelets or plasma to replace what's been consumed, trying to stop bleeding, but carefully, because you don't want to fuel more clotting. Sometimes anticoagulants like heparin are used cautiously in specific phases.
Tricky balancing act.
Very.
And for AKI, the kidney failure.
Dialysis is the main supportive therapy. It takes over the kidney's job of filtering the blood, removing waste, and managing fluids and electrolytes until, hopefully, the kidneys can recover.
And underlying all this specific stuff.
Just intensive supportive care, managing nutrition, preventing complications like blood clots or pressure sores, monitoring everything closely, managing pain and sedation. It's a whole body effort.
Right. It takes a huge team and constant vigilance. Okay, let's try and pull this all together. A quick recap.
Sounds good.
We start with SIRS. That's systemic inflammation, maybe from trauma, burns, pancreatitis, not necessarily infection.
Check. The body's alarm bells ringing loud.
Then, if an infection is the trigger and the body's response causes organ dysfunction, that's sepsis.
Got it. Infection plus dysregulated response plus organ damage.
If sepsis leads to persistent low blood pressure despite fluids needing pressors, that's septic shock.
The circulatory system failing critically.
And if this cascade continues, leading to the failure of two or more organ systems, lungs, kidneys, liver, etc., that's MODS.
The devastating multi-system breakdown.
It really highlights how the body reacts to major insults, doesn't it? How interconnected everything is.
It really does. From that initial trigger, the potential for this widespread damaging cascade is quite profound. Understanding the steps helps appreciate how serious these conditions are.
It's definitely sobering. And it makes you think how different initial events, maybe a car accident versus a severe pneumonia, can potentially funnel down similar physiological pathways of inflammation and shock inside the body.
That's a great point. The body has a limited number of ways to respond to overwhelming stress, and this SIRS sepsis shock MODS pathway is unfortunately a common final route for many critical illnesses.
Really makes you consider the body's resilience, but also its breaking points. Thank you. This has been incredibly insightful, untangling a really complex topic.
My pleasure. It's crucial information to understand.